I'll get this. All right. And I will share my screen in just a moment.
I'll put this on mute for.
My responsibility is to eat this delicious food while I'm here.
So we have quite a bit, so. Can you all see my screen?
Yes.
Excellent.
Yes.
Thanks for coming. I feel a little bit bad being a cis man doing a talk on women's health, but we're going to work on getting some more speakers next year who are going to be a little more inclusive in terms of just representation. So for today, we're going to talk. We're going to talk a little bit about women's health at 55 and beyond. For those who may not know, my name is Michael Danielewicz. I am the director of Pride at the Jefferson Center for Healthy Aging. I am family medicine trained, as I see all ages, but in particular, geriatric medicine trained, which, although I hate that word, is the care of folks 55 and older. So this is a topic that I'm pretty passionate about, just in general, and we're going to do quite a bit today. So I'm going to try to finish at in about 35 to 40 minutes and take questions. As we talk about this, it's important to think about the health of, when I say older women, I'm thinking folks who are 55 and over. Women in general, cis women I'm referring to here, tend to live longer than men. That is, there is always a few years extra life expectancy when we compare women to men. Partially because of that, older women tend to develop more chronic health issues, in part because they tend to live longer. But there's also some realities that I think anyone here who is a woman has lived with throughout their entire life, some of which are economic and social disparities. There is still not pay equity between genders, and this has gone on for decades. So that's affected how many of my patients are able to save and prepare for the future, not to even mention some of the social disparities. When we think about the health of older LGBTQ women, this brings a whole other set of identities into the mix. And as with many of these talks, it would be really, there is a need to focus on some of the negatives that have come with that, such as the fact that LGBTQ women may be more likely to experience discrimination or stigma in healthcare settings, or find providers who are not prepared for or attuned to needs. There is, in many cases, this heteronormative assumption in healthcare, where even today patients are being asked, older women, about their husbands, or just with assumptions being made about male partners and cis hetero relationships. In some cases, because of this mistrust of healthcare, that can result in things like delayed or missed healthcare, especially when it comes to screenings. And we've seen this data. We're going to talk through some of it a little later. These issues around pay inequity, these issues around lack of legal protection until recently for those who are partnered, also has significant impact on how caregiving works, on how saving for the future works, and on how some of the networks that folks rely on have developed. I wish I weren't having to say this, but these days with all that's going on, I'm really worried about some of this as far as the legal protections that are either at risk or actively being stripped away. So with that said, that's kind of a really depressing intro to a really important talk. We're going to try to cover a bunch of different things. We're going to talk about menopause and how that relates to health as well as sexual function. We'll do some time talking about pelvic organ prolapse and what some of that means. We will talk about screenings for older women, specific foci on communities within the LGBTQ realm. And then we're going to spend some time talking about osteoporosis, not just in terms of prevention, but also in terms of detection and treatment. So I know we have a relatively small crowd here, but I'm open to stopping at any point and taking questions. So with that said, I want to start by talking about menopause. What is menopause? It is the permanent end of menstrual periods lasting 1 year or more. The median age for menopause in the United States is around 51, but that varies widely, and some folks can continue to have menstrual periods well into their 60s. These are just some comments that folks have made about menopause here, which are The general idea is that going through menopause is not necessarily a pleasant thing. Some of the aspects we're going to talk about. There are a lot of symptoms of menopause. The one that is most commonly recognized, because in many ways it can be the most obvious and bothersome, are what we call vasomotor symptoms. Vasomotor symptoms of menopause are most commonly thought of as hot flashes. These are the changes in how people feel that can happen due to rapid fluctuations in hormones. Related to that are some changes in mood. Incidence of depression rises sharply around perimenopause and during menopause. That said, I don't want to paint the picture of this as an inevitability that we cannot treat. Due to hormonal changes, changes in sleep may be expected. There's also this idea of this, what they call the genitourinary symptoms of menopause, which we're going to talk through. That can range from things like vaginal dryness to incontinence, which can develop. There are also a number of ways that changes in sexual health and function can happen. Some of these are manifested in particularly negative ways, such as pain with sexual activity or a decrease in libido. So, as I said just a minute ago, vasomotor symptoms are not just the most common symptom. They can often be the most bothersome because so many people have them. These are hot flashes. These can be sudden changes in mood as hormones fluctuate. Up to 80% of women who are going through menopause may experience some of these symptoms, and they last for quite a while. Hot flashes are not the kind of thing that come and go away generally, last an average of between 5 and 10 years. And of those folks who get them, the vast majority of them are experiencing some level of symptoms on a day-to-day basis. So I have folks ask me all the time, seeing folks 55 plus, I see quite a few people who are kind of going through this. People want to know, Doc, why is this happening? The reality is we are not entirely sure. I wish I had a really good explanation for that. We know that this happens. We know that rapid changes in how people feel and how temperature fluctuations affect people. But why hot flashes and some of these other symptoms occur? Not entirely clear. So what do we do about it? There are a number of obvious kind of coping mechanisms that can help with vasomotor symptoms. Some of these here on the right are focusing on the day-to-day lifestyle things that people can do. Wearing layers that can easily be removed, keeping bedrooms cool, considering that some of these symptoms tend to happen at night. Avoiding triggers. Some people may find that their hot flashes are triggered by things like spicy food or even certain types of food. Exercise, plant-based diet as much as possible. That's kind of general good health advice. If these things aren't working, I encourage folks out there to talk to their physicians and providers because we have treatments for it. The most effective treatment still for menopausal symptoms, especially these vasomotor symptoms, is hormone replacement therapy. Hormone replacement therapy it's gotten a bit of a bad rap in the healthcare world. Years ago, going back 20, 30 years, hormone replacement therapy medically was all the rage. Most folks over the age of 55 were at least being offered it, if not prescribed it. What hormone replacement therapy is either estrogen or a combination of estrogen and progesterone. These are kind of the main sex hormones that change and fluctuate during menopause. The reason why, over the past 20 years especially, hormone treatment has gotten that bad rep is due to a 2002 paper that really looked at combined estrogen and progesterone. And it said, wait a minute, there's this increased risk of blood clots. So folks can be maybe familiar with deep vein thrombosis, the clots that usually occur down in the calves. The thought was that estrogen and progesterone increase this. On a longer term scale, there's also concern that estrogen and progesterone together, and for these purposes, increased risk of breast cancer, coronary disease, and stroke. That's really some scary data there. Mm. Even for estrogen alone, there was some concern back in this big 2002 study that there's an increased risk of clots. As with most things in medicine, we take these landmark studies and we really have to keep re-examining new data that's coming out. So recent data where the investigators are actually looking at incidence and prevalence of these things, is quite a bit more reassuring. So I'm not saying that these risks are zero. There is still some concern about all these things. These are discussions that have to be had on an individualized basis. But the idea that we can still prescribe hormones for these bothersome symptoms has come back. And I am open to doing this with my patients once we have honest discussions of potential risk and benefit. Who would I not prescribe, say, a combined estrogen progesterone to? An example would be someone who already has coronary artery disease, someone who has had a history of stroke. We may need to look at some of the other ideas for treatments for those folks. But I want people to feel really comfortable, or at least as comfortable as folks can be, bringing these symptoms to their providers. A lot of folks historically have come to the doctor saying, well, this happens, which is true. This does happen, as we saw, it happens to a lot of people. That does not mean that we don't have ways to treat it and to change the experience in a positive way. There are a number of other medicines that we can use too, in addition to these lifestyle changes, to really work with the vasomotor symptoms. There are a number of medicines that started their lives as antidepressants, such as the SSRIs. These are medicines like citalopram, sertraline, Celexa, Zoloft, and its relatives, or SNRIs, which are a similar class of medicines. Propion or Wellbutrin is the most common. Gabapentin, clonidine. These are all different medicines that, for a variety of reasons, have some level of efficacy in helping vasomotor symptoms. So even if A, you have concern about hormone therapy and aren't really interested in doing it, or B, have a lot of risk factors, it's still worth bringing up these symptoms to your provider because we have a variety of tools in our arsenal to help make folks feel better. I can say, taking care of a lot of folks who have some pretty high risk medical conditions, I've had pretty good luck with some of these other treatments with actually really improving quality of life and symptom burden. So again, bring it up. I want to talk also about what we call the genitourinary syndrome of menopause. Now, as folks age, estrogen levels go down as women age. And this can result in a lot of changes to the natural vaginal tissue, some of which can be bothersome from a sexual sense, and others which can be bothersome from a urinary sense. Some of these are vaginal dryness, thinning in the mucosa, that top layer of the vaginal tissue, changes in caliber of the vagina, mainly a narrowing and shortening, and changes in tissues of the urethra. So the urethra is the tube that urine comes through, and there can be similar changes in terms of change in route, change in tissue that can affect some things that we're about to talk about. So as these things happen, we can start to see some of these aspects of what we call the GU syndrome of menopause. And it's pretty common, 10 to 40% of women. My patient population who are women, I would say it's probably significantly higher. Vaginal dryness is not something that we should just write off. And if you've had that experience, on behalf of medicine, I'm sorry if that's being written off. It can manifest in a lot of different ways, from burning to discharge to bleeding, irritation, a feeling of irritation. If you're having some kind of insertive vaginal sex, that can be really painful. Changes to the urethra, too, can result in a lot of things that people might mistake for urinary tract infections. Urgency, frequency, discomfort, and also result in more frequent UTIs by itself. These are changes that happen to some degree with age. There is, again, this is not a hopeless story. This is something that we can do about. Topical estrogen is really the hallmark of treatment for what we call the GU syndrome of menopause. And the nice part about topical estrogen is that it's really, really safe. It is not associated with the risks of those estrogens that I was telling you about before that tend to be by mouth or by patch. So, topical estrogen can help with vaginal dryness, can help with urinary issues, that frequency, urgency, and even some forms of incontinence that may happen. three different types of estrogen, and it's not super important to go through each one now. But basically, there are two main creams that at first, for the first few weeks, people are inserting on a daily basis. Once that builds up enough after 2 weeks, we generally tell folks to go to twice weekly dosing. There's also, for those who don't really like the thought of having to remember or even having to put something in on a regular basis, a vaginal ring that contains estrogen that can be placed either by a provider or by the patient themselves in the vaginal canal, where it sits for about 3 months. Now, when we're thinking about vagina and how things change as folks age, some of these changes in the mucosa, from the dryness to the thinning, changes in the pH, or what we call the acid-base status, due to changes in natural flora, things that naturally, bacteria that naturally lives there, changes. And this can, as I said before, result in increased risk of urinary tract infections, but it can also cause a certain number of inflammatory conditions. So things like odor, discharge, or irritation, these are things that may become more common with aging, but I don't want any women out there to feel that these are things that just have to happen and can't be treated. Again, folks have not always felt comfortable bringing these things up to their providers and doctors because admittedly, we are really bad at asking about these in our patients over the age of 55. I think that's one of the things that we're trying now on both local and national level to change. So the reality is that yes, there are a couple of what we would call infectious causes of vaginitis, not necessarily sexually transmitted, but things like bacterial vaginosis or yeast infections that can all present in different ways and may become more common as folks age. Again, these are things that we can be treating. These are things that I want folks to feel empowered to ask about. Now, when we think about the vulva or some of the more external tissues, things tend to change there with age too. Again, that epithelial or top layer of skin cells tends to change, becomes less elastic. There is less fat padding. So you have a thinning not just of the outer layers, but also some of the inner layers. Irritation can occur to this tissue. As folks age and if they have greater issues with holding urine, or if they're using cleaning products on the vagina or the vulva, even ones that they've used earlier in life, these can become more irritating as folks age. I want to say that folks who are having burning or pain of the vulva in particular, this is rarely due to lack of estrogen, whereas a lot of these symptoms are related to estrogen. So I really want folks, again, note changes, don't just make assumptions that it's normal aging. Some of it may be, but there are also a number of different types of vulvar skin issues that can come up as women age. And I don't think we need to go through them or show pictures of them today, but the reality of knowing that they're out there, some of which are changes of the skin so that it may become paper thin, some of which may be even what we call vulvar neoplasms or cancer, with the caveat that cancers are very rare. So again, paying attention to these changes, being aware that some of them may be aging, something doesn't. Any questions about menopause or the GU syndrome of menopause before we move on? So I wanted to spend some time today talking about what we call pelvic organ prolapse. And what does that mean? So there are a lot of things that change with aging, as I just mentioned. As some of the tissues in the pelvis change, some of the support structures that hold things in place can change too. So that can result in things, followed by the uterus, if folks have a uterus, followed by rectum, looking front to back. In this second image, we have what's called a cystocele, where the bladder starts to essentially, for lack of a better word, the bladder starts to drop. So the bladder does what we call prolapses or sticks out in a way that it normally shouldn't. Cystoceles can be really bothersome because they can do a few things. One, they can make urinary episodes more unpredictable. Bladder is not shaped as it should be, when it's not located where it should be, that can be really irritating. So it may be harder to hold urine in. On the other hand, depending on how things look, it may be harder to get urine out. So I've actually seen over the course of my career, some women who have to do what we call splinting, manually replacing with fingers certain organs, usually the bladder, to kind of move things around to make the urine flow normally. Uterine prolapse is another thing that happens, not to everyone, but certainly can. You see here that the uterus is way higher than it is here, way lower than it is here. Some of the ligaments that normally connect the uterus to the abdominal walls or to the pelvic walls, as folks age, can get more elastic and loosen. So the uterus essentially drops down. How much this happens can really vary. For some people, it can be that things, say on a vaginal exam, where the uterus is a little bit lower. In really severe cases, this can actually result in the uterus being visible to the naked eye without an exam. The last thing that I want to talk about is erectocele, which is fairly similar to a cystocele, but in this case, it's the rectum that's dropping. So again, some of the ligaments and things that hold things together as folks age can change. Support structures change, the rectum can drop down, which can make it harder to hold stool. So I want to make sure that we talk about all of this. Pelvic organ prolapse to some degree, any of these things, whether it's rectum, whether it's uterus, or whether it's bladder, is really common. Now, 40 to 50% of women have this to some degree. When I say that, I am not talking about people where the uterus is visible to the naked eye. It's usually a much smaller change. The good part about this is that only 3 to 6% of people get this to a point where it is symptomatic or bothersome. And who gets that? One, age is a factor. Folks who have had a family history of organ prolapse are more likely to develop it due to factors not fully understood. Obstetrical history. Those who have had children or those who have had especially vaginal deliveries may be more likely to develop this. As we said, menopause and some of those tissue changes can really change how the tissue behaves and what happens. And then the final two are results of increased intra-abdominal pressure. Chronic constipation really can make this more likely to happen. As people bear down and try to have a bowel movement, increases the pressure within the abdomen and pelvis. In a similar way, heavy lifting. Folks who are bearing down to lift things, especially folks who may not have done it properly all their lives, are more likely to have, say, erectocele. And the symptoms, as I said, can range from a bulge or pressure to these bladder issues to other bowel issues. Now again, these are things that we can only treat if we know about. So there are a couple of things that we can do before we think about medicines and surgeries. The first step is lifestyle modification. The goal is to really improve symptoms associated with prolapse. The first step of this is usually what we call pelvic floor strengthening, where we will actually send folks to specialized physical therapists who can teach folks how to do certain exercises that strengthen the muscles in the pelvis, help keep things where it belongs. Some of this involves Kegels. Kegels are things that people can learn themselves. Kegels being exercises that train folks to use those pelvic muscles and to tighten and relax them on their own at home. For folks who have this prolapse of the posterior vaginal wall, which would look more like this, where the back wall here starts to weaken, can really rely on fiber supplementation, laxatives to help keep stool moving in a way that doesn't apply extra pressure to the area. We want stool to generally be soft. We want folks to have a bowel movement at least one every 3 days. If you are not having bowel movements once every 3 days, regardless of why, urge folks to speak to your doctor. When it comes to urinary incontinence, lack of control of urine becomes more common as folks age. There are a lot of ways that we can do what's called bladder training to help get things back to some level of regularity. one of which is timed voids. What I mean by this is having someone use the restroom to urinate every set number of hours, whether you feel the need to or not. Every 4 hours is usually the first recommendation. That can help train the bladder to allow you to control it as opposed to your bladder telling you, I'm full and I'm going to empty right now. Adequate hydration is really important, especially when it comes to doing what I admittedly don't do, which is avoiding caffeine, especially later in the day. General rule of thumb is that you should not be having caffeinated beverages after 2 p.m. Caffeine does stick around, whether you notice it or not. The more caffeine people have, caffeine is itself a bladder irritant. It causes bladder spasms. Caffeine is also a natural diuretic, meaning it pulls water out. It dehydrates folks. And then for folks who are on diuretics, medicines like hydrochlorothiazide, chlorthalidone, Lasix, these are all medicines that, for one reason or another, make folks pee. And so making sure you're taking those medicines at the right times. I see some folks come into me where they're taking diuretics twice a day. Lasix is a medicine that sometimes, for reasons of heart failure or whatever reason you're on it, swelling in the legs, people may need to take it twice a day. But that doesn't mean you have to take it at 9 o'clock at night before you go to bed. Twice a day for Lasix might look like taking it at 8 a.m. when you wake up and at 3 p.m. in the afternoon, because Lasix lasts about 6 hours. So talk to your doctor. Now, if none of these lifestyle modifications work, for certain patients, we are now thinking about how do we fix the prolapse with more medical intervention. And there are really two ways to do that. One are pessaries. Pessaries are these rubberized plastic devices that essentially get placed into the vagina to help things back to their normal position. There are a variety of different shapes. There are a variety of different types. You need to see your doctor, usually a GYN specialist, to help you decide which one is right for you. Now, for some patients, I have a number of patients who use pessaries. They can really help with symptoms. Some folks feel more comfortable removing them themselves and replacing them. So I have patients who do their own pessary maintenance and take them out and clean them every week. For some folks who either A, don't feel comfortable about doing that, B, it can be really hard to get into the right position to change a pessary, or it can be really uncomfortable. Providers, people like us, can change them every 3 to 4 months for folks. You just always need to make sure that you have those appointments in place. Now, some people think about the idea of pessaries and they say, absolutely not. I have tried every lifestyle modification out there. I do not want to deal with pessaries. So there are a number of surgical options, from bladder slings that essentially can pull the bladder back up, to repairs of wall defects. I encourage you to talk to your doctor about those. First thing we always do is we talk about lifestyle modifications. Questions about pelvic organ prolapse, about urinary issues, about incontinence, anything at all? Right. Hearing nothing, I'm going to go on and talk about screenings for older women. Again, when I say older women, 55 plus, and I'm going to focus on some of the screenings that are more specific to women. I am happy to get into things like colorectal cancer screening, because it is extremely important, but I am going to focus on some of the more specific screenings for folks who have breasts and who have either a cervix or a uterus. In the field of geriatric medicine, my field of medicine, you will hear us talk all the time about when is it appropriate to screen, or when do we recommend discontinuing or retiring from screening. The reality is that every screening and every intervention we offer in medicine has some level of what we call lag time to benefit, meaning we need to do it for a certain amount of time before we'll get some benefit. For breast and colon cancer screening, it really takes about 10 years to see that benefit. So if someone has, no matter what their age is, a lot of medical comorbidities that make me worried that 10 years is a pretty optimistic focus, we may have to talk about that as far as To what degree is it going to be helpful to be screening for these things? Other things like we're going to talk about osteoporosis and bone density. Starting a bisphosphonate, which is one of the more common medicines for low bone density, the benefit is seen within a year. So again, we need to be thinking, and my field does this pretty well, thinking not just about life expectancy, not just about age as a number, but thinking about functional status. What do I mean by that? How are people doing in their day-to-day life? How are they getting around? How much assistance are they needing with certain activities? And that can help us pinpoint what are the most helpful interventions to discuss, what are the most helpful things to offer. So again, individualized discussions are really, really important in these settings. We are not trying to set blanket rules for anyone. And if someone feels really strongly about continuing with the screening, I'm happy to do it. You just need to have some discussions sometimes. So with that said, cervical cancer screening is typically done via what we call cytology or a pap test. And in both women having sex with women, trans men who have a cervix, we know that the rates of cervical cancer screening have historically and continue to be lower or delayed. Part of that is the thought that, well, this is a thought that came from some logic and isn't quite accurate, which is that there is a difference in women having sex with women or lesbian women in the rates of HPV infection, human papillomavirus, meaning the rate of HPV infection has historically been lower in lesbian women and other women having sex with women. The thought behind this was if HPV is one of the leading causes of cervical cancer, then logically, if we have less HPV, we will have less cervical cancer. And that's where our problem is that as data gets better, because it is still certainly lagging in our lesbian women, there is no difference in the rates of abnormal screenings. So I would encourage folks who, if you have ever been told that because you are a lesbian or because you have partners who are women and you are a woman, you've been told that you don't need cervical cancer screening, you really need to revisit that and really question whoever told you that one. Now, when does one need cervical cancer screening? And the idea is that we're generally screening folks through age 65. So I have patients who are 66 years old and come into me all relieved and say, well, I never have to get a pap smear again. I'm really happy about that. No one loves that exam. I don't blame them. But there's a big asterisk next to that stop at age 65. You have to have had 3 screenings in a row that have been negative. Theoretically, your most recent screening should have been within the past 5 years. So you can also discontinue. Obviously, if you've had a complete hysterectomy, you don't have a cervix, you're not going to get cervical cancer because there is no cervix. So oftentimes when someone comes in, whether they're 66 or 74, and they don't have data, I will at least bring up the idea of, should we consider doing one last pap or one last cervical cancer screening? That's often the most people are kind of willing to agree to, which I don't blame them. But it helps us from a prevention perspective. I've had at least one in the past 5 years, unless somebody had those 3 normal ones. So what about people who don't feel comfortable getting a pap? What about people for whom a pap is really uncomfortable? What about folks who what about our trans folks? We're gonna have a whole talk on that next month about trans folks who have a lot of dysphoria from the idea of having a speculum inserted. There are other ways to test, one of which is a self-pap, meaning we do a brief instructional tutorial with the help of either a video or a model, show folks how to find their own cervix. We ask them to find it. We give them a small swab to get whatever tissue they can. Meaning, when I say whatever tissue they can, you swab the area as best you can. It's probably not as good as having a provider do it with the view of a speculum, but it is better than not doing anything. There's also increasing data that testing for human papillomavirus only may be coming down the line at some point, meaning folks who have HPV in their vaginal canals we know that they are higher risk for cervical cancer development. So major societies are working on how do we work that out into guidelines. TBD. Breast cancer screening, most frequently done via mammogram. There has been some controversy about mammograms. So if you look at the American Cancer Society and compare that to one of the other big bodies that comes up with a lot of these regulations and recommendations, the United States Preventive Services Task Force, the American Cancer Society says, hey, let's start at 40 and do it every year. USPSTF says every other year. They also differ on when do we consider stopping. Now, if you remember back to a few slides ago, we said the lag time to benefit of breast cancer screening is about 10 years. So the American Cancer Society takes a very practical approach and does not put a number on it and says, continue screening until life expectancy is thought to be 10 years or less. I'll say that's a tough conversation to have with people. It really is. I certainly have folks who are quite medically frail. They have an accumulation of pretty serious medical comorbidities or problems who still want to go forward with breast cancer screening. Yeah, I'm okay with that. I think I do bring up some of the risk of that as far as what if we find something? What if we find something that isn't going to clinically change your life course? It might change the time you have to spend getting procedures, the time you spend seeing me in the office or seeing an oncologist. US Preventive Services Task Force gets a little more concrete with it. Well, they both get more concrete and also completely whiff and say, we have insufficient evidence to say risk or harm past age 75. The reality is it has not been studied very well. What you will see commonly is that folks will often say, past 75, we generally don't do mammograms. And that's true again with an asterisk. You know, my chart system stops flagging them after 75. But if folks, I try to have a discussion with everyone about this right around the age of 75 or younger if they have a lot of medical issues. Osteoporosis screening is another really important one. Osteoporosis, we're going to spend a few minutes talking about as its own thing. Oh, here we're trying to look at decreased bone density. Think about decreased bone density. We'll look at pictures of what bones look like. And when you see those, you really recognize how folks with osteoporosis are at an increased risk of breaking something if they fall, particularly the femur or the hip or compression fractures in the spine, particularly in the lumbar spine. Lower spine. The screening generally starts at age 65 for all women. For those who have risk factors, meaning for those who have undergone menopause early, for those who may have had a hysterectomy, for those who have had other hormone therapies, we may consider starting earlier. So there's a kind of a whole list of risk factors that I keep in my head and in a chart that says, look, these are the folks who we need to think about screening at 58, 59. Screening is pretty easy. It's done via this DEXA machine. So people often get scared thinking about, oh, you have to look at many parts of my body. Is this going to be something claustrophobic? Is this going to take a long time? Fortunately not. This is an entirely open test. It uses only X-rays with very minimal radiation. You actually get about the same amount of radiation if you've ever gotten a chest X-ray. And what this device does is it takes a variety of specific X-rays looking at the hip, the lumbar spine, and a few bones in the leg to get a sense of what is the bone mineral density in those areas. And if we find something abnormal, we'll talk about what that means. That is recommended at age 65. Medicare will pay for a DEXA scan every 2 years. So oftentimes what we'll do is we'll check one at 65. If it's normal, for some folks, we don't revisit it. If it shows this gray area of what we call osteopenia, which talk about what this looks like, the bone lattice is starting to thin, but not quite meeting osteoporosis, we might repeat it in a few years. We'll talk about prevention in just a moment. As I said, sexual health, we in medicine are admittedly terrible at asking folks this. There is a common implicit assumption that folks don't have sex when they are over 55. And I can tell you in talking to my patients, we know that's not true, and we're trying to change this paradigm. We also know that older folks are less likely to use protection against STIs, less likely to get tested, oftentimes because we're not asking. There is also this common and dangerous assumption that women who have sex with women are at a lower risk of STIs. But data has actually shown that's not true for certain conditions, some of which are listed here. So what I will say here without getting into the weeds is, if you've had recent new sexual partners, especially if you're not using some sort of barrier protection, does it matter what parts are in contact? You should be talking to your doctor about screening and talking about, if you're comfortable doing this, what sorts of sex you might be having, because that can affect what we do. Questions about screening before we jump on to our last section, which is osteoporosis. This is a topic every geriatrician gets really excited about osteoporosis because we do this a lot. So what is osteoporosis? As I said, the bones are made up of a lattice work. You can see the images here. I'm highlighting it for those where this lattice work is strengthened when it's dense. So in the bone, there are a variety of cells. Bone is living tissue. People don't tend to think of it that way. Bones are constantly growing, changing, not so much in their overall shape, but in their internal structure. There are cells in every bone that help to break down old bone fragments. There are cells that help rebuild new bone. A lot of this is mediated by estrogen levels. Estrogen helps support strong bones. So as folks go through menopause and estrogen levels decrease pretty much across the board, that puts folks at risk of what we call osteoporosis, this thinning of the matrix that you see here. A lot of factors behind it. Sometimes those cells that I mentioned that eat or take apart the bone increase with age. Sometimes also the cells that help build new bone decrease. So in certain folks, this can become the perfect storm of increased what we call bone resorption. Okay, your body's taking apart your bone lattice, but it's not able to rebuild it fast enough. And that's when we start to see osteoporosis. So how do we prevent it? Because this is the question that we get a lot. And the reality is the number one thing that folks can do to support healthy bones, yes, diet helps. A diet, we'll talk on the next slide, weight-bearing exercise of any kind. Osteoporosis tends to affect the parts of the body that bear the most weight, hips and lower back. So things like walking, running, stair climbing, some degree weightlifting, yoga, tai chi, even simple sit to stand exercises can help prevent osteoporosis. Tobacco use, avoiding smoking as much as possible. Some of the compounds in tobacco smoke, in tobacco products, directly inhibit those cells that help to rebuild bone. Alcohol consumption, 1 drink a day or less is ideal for women. Alcohol consumption not only affects bone density, it makes people more likely to fall. As somebody who is clumsy anyway, I understand that. Working on fall prevention, balance and improve balance exercises, working with physical and occupational therapy, modifying home safety environment. As a geriatrician, one of my biggest enemies in the home, row rugs, especially the ones that are unsecured. They can be really dangerous. And then diet, which we're going to talk about on the next slide. So sorry, this came out a little blurry, but this is essentially a slide on eating for healthy bones. You know, calcium is a controversial thing in medicine. Every couple of years we decide, yes, people should have a lot of calcium. Wait, no, maybe not. Right now we've landed somewhere in the middle that we want people to get an adequate dietary calcium intake. Come from dairy or leafy greens, beans, fortified foods that have additional calcium added. What we've also learned over the years is that vitamin D is also really important. So fatty fish like salmon, cheeses, eggs, sunlight. Everyone in Philadelphia is probably vitamin D deficient at some point during the winter. Proteins can also be helpful. So there's a sample plate here that you all can take a look at. The idea behind all of this is ideally, we're getting the right amount of supplementation from what we eat. I encourage you also, if you're a woman over the age of 55 and you're postmenopausal, talk to your doctor about what they might want you to supplement with. I will say, as a geriatrician, people come into me and ask all the time what supplements are helpful. I'll be honest, the majority of them don't have great evidence behind them. The ones that do are a certain amount of vitamin D supplementation, and for certain folks, calcium supplementation. Why I say certain folks, if you have really bad heart disease, a lot of cardiologists don't want us adding more calcium that can build up in the arteries. So before you start anything, talk to your doctor. But I encourage you, if this isn't something that's been brought up to you, talk to your doc or your provider about how you can prevent osteoporosis. Now, this is an example of a DEXA scan here. It gets really, we don't need to go into all of this, but it looks at the angles of the hip, it looks at bone mineral density, and then it gives us some numbers. So go to your doctor, they give you this diagnosis of osteoporosis. What do we do now? I mentioned these medication class called bisphosphonates. These are some common names: alendronate, risendronate, ebandronate. They all have very fancy trade names, but they're often taken on a weekly basis, and they help over time build up bone density. Now, you have to take these medicines while you're sitting up and with tons of water. Why? Two reasons. One is that they're pretty big, generally. Two, they are not well absorbed by the stomach by itself, so they need significant fluid because they do sit in the stomach for a bit. Three, if they do not go all the way down, or if you have any level of reflux, like gastrointestinal reflux, they can cause irritation of the esophagus. So always take them sitting up by themselves with a full glass of water, wait 30 minutes to an hour before taking anything else. You will have us ask you before you start a bisphosphonate if you have dental issues. Namely, have you had dental extractions or do you have dental decay? Why? Because one of the feared and less common side effects is what we call jaw osteonecrosis. These medicines, bisphosphonates, work on some of those cells that help break down bone. Bisphosphonates stop those cells from breaking down bone. Problem is, the way that these cells work in the jaw is a little different, and in a very, very small subset of cases, you can get some level of jawbone depth or necrosis. There is also this slightly increased risk of what we call an atypical femur fracture. As bone density builds back up, you might see folks, you have a really bad fall, folks on bisphosphonates may be protected from some of the more normal fractures, like a normal femur fracture. There's one specific subtype that's more common. Now, bisphosphonates. Say you've met with your provider, they say this is not right for you, or you say, I've gotten such bad reflux, never doing that again. There is an alternative called denosumab or Prolia that is an every 6-month injection. Similar to the less common side effects, really they have the same risks, this one minus the reflux. So both of these medicines work on those cells that break down bone. There are other medicines that actually can help build bone. These are a little, I would say, second and third line. Why? One, because they are extremely expensive. Two, because we have to be more careful with how long we use them. So we reserve these for severe osteoporosis, or if for some reason it's not an option. So when we treat with bisphosphonates or denosumab, Prolia, we're generally looking at being on that medicine for at least 5 years. During that time, we're often not looking at bone density within that 5 years, because there has been evidence that just being on these medicines and having these bone changes occurring, even if your bone density doesn't go significantly up, they are still helpful to protect against fractures. With some of those bone building medicines, we really have to restrict them to 2 years, as we start to see a rise in side effects after 2 years. This is just a really well done little diagram of these cells called osteoclasts that break down bone. Osteobone, clast, break. These bisphosphonates, medicines like these guys, actually help to stop those cells from working. So they help prevent breakdown. Bisphosphonates take some time and they build up in the blood, and they really do, in the bone, sorry, and they do hang around for a while. So the idea being that we're trying to stop this fast turnover of bone, knowing that the body breaks down bone, and may not be as good at building it up later. So that's what I have today. There is, obviously, this is not even close to everything we could talk about when it comes to women's health. But this is a kind of quick 45-minute overview, and appreciate you all joining. Anybody have questions?
Hello,
Hey,
Hello.
hi, it's Suze. I do have a question. This was very well presented, very interesting. Um, I'm 30 years post-menopause. Uh, I went through it like a flash, didn't bother me. I think I had symptoms for 2 or 3 months. And the hot flashes I converted to power surges and I was able to deal with it that way. Um, I have questions. I'm going to be 81 next month. And everything you've talked about, of course, has had 30 years to work on me. I am also in cancer treatment, and I very often ask both Dr. Parks, who's my primary, and Dr. Vaughn, my oncologist at Penn, when I get symptoms that I haven't had before, I have to ask him, is it because of my age that I'm having, I'm so tired today. I'm just using that as an example. Is it because of my age? Is it because of the cancer I am fighting? Or is it because of the treatment? And everybody just throws their hands up, because there's really no answer. But is there any place I can look, any research available to me that might give me some information? I've never been almost 81 before, and I've never been in chemo, and then this enfortumab, which is an MAB, and all that entails. I've never been in that. I've been in that treatment for almost 4 years now, and I had surgery and the cisplatin gemcitabine before that, and lots of surgeries. I'm still here. I intend to be here. My parents lived till their late 90s. Is there some research that might be available that would tell me, oh, this is more likely to be from the treatment, or more likely to be because you're 80 plus years old?
Admittedly, I have a very unsatisfying answer to that. I'm really sorry. It is, you're describing the challenge that we all have, and probably why you've been getting those answers. Because admittedly, sometimes even we're not sure what's coming from what. Aging does come with its own specific changes, some of which are normal aging and some of which are very much not. So unfortunately, you can, there are certainly ways to look out there. I mean, everyone's familiar with WebMD these days, but WebMD is not going to give you the nuance that you're looking for. And so I don't, off the top of my head, I will ask Dr. Parks if she has anything and get back to you, because I don't have a resource that easily pinpoints, because admittedly, we have trouble with this sometimes too.
Okay.
Sorry
Yeah,
for
well,
that.
we see Dr. Parks, my partner Mary and I, about every 3 months, 2 to 3 months. Mary is, knock on wood, healthy, and it's just a checkup, and I'm trying to keep Dr. Parks informed if she knows of some silly little thing I might be doing that is adding to my issues. We go over stuff like that.
And
Thank you.
that's
It's just, yeah.
from my perspective, working directly with Dr. Parks, as you know, I think that's a really good way to do it, though. I mean, bring the questions up, even if they seem small, is my advice, because there are always little things can become annoyances. Annoyances can really affect quality of life. So I encourage you to keep doing exactly what you're doing. Sorry, I don't have an instant way for us to figure out what's what necessarily.
It's funny because just a few months ago, the pain management group at Penn that I work with, that sounds impressive. I'm a patient. Said you can stop taking all those vitamins. You've been taking the multivitamins and the vitamin C. You don't have to worry about all that. And then a few weeks later, CDC comes out with, or whoever came out with,
Right.
oh yeah, they're really good for you. So,
It's
good
one
thing.
of our challenges, admittedly, is as guidelines change, I think even about hormones, like I said earlier, things have changed even since I've been in medical school within the past 10, 15 years. And given a lot of the issues that we've had with modern healthcare in this country, some folks look at that kind of experience that you just had and will say, oh, they don't know what they're talking about or what's going on, and people get suspicious.
Yeah.
I'll say, I think of it as a good thing that we're constantly reevaluating. I mean, the cup of coffee that I have sitting in my office, every 4 or 5 years, somebody will say that's either going to give me great cardiovascular health or heart attack at 50, depending on what. So I appreciate your commentary. I'm sorry this camera keeps swinging around. I don't know why it's doing that.
Oh, I feel like I'm on a boat.
I know. I do have to run off to clinic, everyone. I appreciate you participating.
Yeah, thank you.
Yeah, thanks a lot.
Thank you so much.
Do you have something, Ed?
No, I was just applauding.
Oh, thank you.
Thank you.
Hi, Ed.
I
Ah.
guess that's it.